On-the-scene coverage of ACC.14 is supported by Janssen Pharmaceuticals, Incorporated.
Hello, I'm Tony DeMaria from UC San Diego, and I'm here at the ACC meeting in Washington for On the Scene, and we're going to go over the highlights of today's meeting. And with me is Fred Beauvais from Temple University in Philadelphia. Fred, the HEAT PCI study was very interesting, wasn't it?
I thought HEAT was a great study. That was a study of 1,800 people getting primary PCI for an ACS, a STEMI. The question was whether heparin or bivalirudin was better in preventing subsequent endpoints. 28-day follow-up, looking at MI, death, stroke. The gist of the study was that the heparin data came out better than the bivalirudin data, which I think was a surprise to the investigators, but it turns out that it doesn't look like we're winning by using bivalirudin, and of course the cost is tremendously different between heparin and bivalirudin.
Sure, and all of this was predicated on provisional use of GP2B3A agents if necessary, ReaPro. And I was surprised too. Of course, in terms of death and stroke, there really was no difference between the two. It was target lesion revascularization and periprocedural MI.
Well, of course, the British have this thing called NICE, the council that looks at cost and everything. And I think this is going to be an interesting discussion because they've already approved bivalirudin, and now this is going to come up again for question because of the difference in cost between the two drugs.
Yeah, an interesting study in that, although it was single center, they got a large number of patients and they randomized virtually 100% of the patients. Very interesting. Now, there were two POISE studies that were presented today, and both of these studies tested the ability of a prophylactic agent to reduce events in the perioperative period for non-cardiac surgery. And the first POISE study employed clonidine. The idea being that clonidine was a vasodilator, would handle blood pressure, and even had some anti-inflammatory effects. And so the clonidine was given intraoperatively, and interestingly enough, did not produce any benefit on the primary endpoint, and in fact actually induced a bit more hypotension.
Well, I think in the early post-op period, when you have anesthesiologists and critical care people very tuned into blood pressure, if you give a medication that's going to drop the blood pressure in this environment, I think you're going to expect that it's going to cause more problems than other ways of managing elevated blood pressure post-surgery. And so I'm not surprised that the clonidine actually caused more complications in the post-op period than not using clonidine.
Sure, and the other POISE study tested aspirin, an interesting strategy given the fact that most surgeons don't like to have the patients on aspirin when they do their surgery. And there was a short-term aspirin and a longer-term aspirin arm. And very analogous to the earlier POISE study with clonidine, aspirin did not cause any beneficial effect and in fact resulted in a higher incidence of bleeding.
And I think the surgeons would basically say, "We told you so."
We told you so, yeah. So the take-home message is for non-cardiac surgery patients, stay away from clonidine and aspirin. So Stampede presented some more data on the long-term effects of bariatric surgery.
Well, this is a very interesting topic because with the new Accountable Care Act, people are asking whether bariatric surgery will be covered by the insurance. A big issue because there's so many obese patients out there. And the question we ask is, do the patients really get metabolic and risk benefit besides just losing weight? And I think the first report from Stampede suggested that they did. And here we are with a 3-year follow-up suggesting, number one, weight can stay down and the metabolic effects are sustained. So I think it's an encouraging study. We do now, although reluctantly, start to recommend bariatric surgery for a lot of these patients who are really not able to get their weight down. So this is, I thought, an encouraging result.
Yeah, it really is. It'll be interesting to see if this results in hard endpoint reduction, enhanced survival, fewer strokes or myocardial infarctions. But so far, a good hypoglycemic effect, and as you say, metabolic syndrome very much reduced. Now, the ZEUS trial was a trial of the zodorolimus-eluting stent, and zodorolimus has been shown to elute the drug faster than most, and so the hypothesis here was that in patients with a relative contraindication or relative risk of drug-eluting stents, so acute MI, in a high bleeding risk, that in fact using the zodorolimus-eluting stent would enable you, in conjunction with a customized program of dual antiplatelets, to get a very beneficial effect, even with the drug-eluting stent in these patients who are relatively at some higher risk. And in fact, that's what they found. So some evidence, again, that maybe prolonged dual antiplatelet therapy isn't absolutely required with these newer drug-eluting stents.
Yeah, well, we all want the endothelium to come back as fast as it can after the stent is put in. The anti-metabolic drugs that are in the stents, basically, I guess people are concerned it inhibits recovery of endothelial function for many months in some of the older stents. Now, here we have a drug that's eluted within 2 weeks, and it prevents the early thrombotic risk and then begins to allow endothelium to come back quicker. So I think that concept looks like it's been supported by the hypothesis that they tested here. Quick recovery, get rid of the anti-metabolic effects of the drug in the stent quickly, let the endothelium recover, and you don't need as much antiplatelet drug. So I think it sort of fits the concept.
Yeah, more data to support the increasing movement to drug-eluting stents whenever possible. The last study that was of interest wasn't exactly a study, it was a report from the TAVR registry that was FDA mandated. David Holmes presented on what's actually going on for TAVR in the United States, and it looks like the results are pretty comparable to what was seen in other registries and the randomized trials.
Yeah, I think the key to this is as we look out a year or so and have the registry, we start to see convergence of the outcomes between surgery and TAVR. And I think that's an encouraging piece of information because early on, you could hypothesize a bunch of things with TAVR that you can't anticipate, but it looks like the longer-term outcomes are starting to come together for either technology right now.
Sure, and it's encouraging that in the registry where there were less experienced operators and where the heart teams were just getting used to selecting patients who were best put in one arm or the other, that the results held true, that it looks like in the real world, so to speak, as that term's often used, that TAVR is performing about as well as it did in the early trials.
I agree, and I think right now we still are living in a very stringent selection process for TAVR, and I think as what's going on in Europe, the requirements are starting to relax a little bit. That'll be the next question. If we relax the requirements, are we still going to see comparable outcome results?
The one finding, of course, was an increased risk of stroke in women, interestingly enough. So we'll have to keep our eye on that and see if it turns out to be an identifiable risk factor in the future.
Yeah, that's an interesting issue because it comes up in the AFib data as well, is that women seem to be more likely to have a stroke than men in some of these different interventions.
Yeah. Well, again, lots and lots of new information at the ACC meeting, much of it negative, but several interesting positive studies that may alter therapy and management in the future. For On the Scene, I'm Tony DeMaria.